All right, now I'm going to introduce our last speaker of the session, Dr. Chi Lin. She's one of the radiation oncologists, a professor and vice chair of research in our Department of Radiation Oncology here at Nebraska Medicine. She's going to be talking about some of the SBRT clinical trials going on for pancreatic cancer at our institution.
Thank you, Mike. So I think we are all too serious, so I'm going to give you some fun. So I came here in 2006, and at the time, actually, pancreatic cancer, we are all doing the concurrent chemoradiation. Standard was 6 weeks of radiation with infusion of 5-FU. Usually by the end of 3 weeks of radiation, because at the time those radiation field is quite big, it's kind of like 1/4 of abdomen in the radiation field. So they all look like this. They all have a very bad diarrhea, admitted, need an IV. And so I was thinking, what can I do? Can we use a smaller field? The concept is that if you cannot take care of gross tumor, why do you worry about microscopic disease? So I can let the Kelsey to take care of microscopic disease. So I shrink the field and want to do the SBRT. At the time, actually, there was no fractionated SBRT for pancreatic cancer. The only SRS was from Stanford. They did the 25 gray in 1 fraction. So I said that if they can do 25 gray in 1 fraction, I can start the 25 in 5 fraction. So that should be safe. So my intention is to make them from this to this. So my SBRT patient, actually, everybody's happy. Everybody's saying that before they realize they're done with the radiation. So that was my motivation. So our first clinical trial here, well, you can see that from IRB number 44107, meaning we started concept was 2007, and we started accrual 2008. Basically, that was a neoadjuvant trial. All the patients had neoadjuvant chemo. At the time, the chemo regimen was gemcitabine and 5-FU. And then followed by 5 fraction of SBRT. Like I said, I started with a safe dose, 25 gray, and then move on to 25, 30, 35, 40. And we also used norfenamide as radiation sensitizer, and norfenamide dose also increased from a half dose, 625 milligram BID, to full dose of 1250 milligram BID, and from 3 weeks up to 5 weeks. And those patients who eventually become resectable will go for resection. Senator Dr. Lee. And that was the trial, actually. We accrued 46 patients, and actually only 39 patients completed treatment per protocol. So we only analyzed the 39 patients. Median age was 63, and about 60% of patients male, and most of them are actually doing well, ECOG 0 or 1. So tumor size was pretty big, actually. Median was 3, and our PTV was pretty big. It was median was 125 millimeter cube. So the patient, actually, 56% they are borderline resectable. Actually, this is my old slides, but that's okay. The new slide didn't. I thought it replaced. That's fine. So the new slide actually also showing the. Oh, I guess I actually have something. Okay, that's fine. Just keep going. A new slide, actually, I was showing we see the dose response. We see the pathological response. When we increase dose, we see more response. And we do have 1 complete response. And the panel A, you can see that that's our failure rate. The failure rate, local failure rate, only about 20%. And the B panel, you can see the overall failure-free survival is overlapped with the distant failure-free survival, meaning most of the patients die from distant metastasis. And the C panel shows the overall survival. This is overall survival is counting from the day of SBRT, not from the diagnosis. So that's why median overall survival is 14 months. And when you compare the resected to non-resected, the resected patients, they are doing better. But because of the initial, you see a little bit overlap. That's why the log rank P was still not significant. Very interesting data is the panel B. For those they did not get the resection, when you use the dose to compare them, 35 to 40 compared to 25 to 30 gray, you can see that the overall survival rate is significantly better than the high dose one, significantly better than the low dose. If you look at the toxicity, actually it's tolerable. We have 21 grade 2 events, and that's actually in 16 out of 39 patients. Grade 3, 11 events, and grade 4, 2 events. But among these 11 events, 4 events among this 11 plus there's 2 is from 1 patient. So we do have 5 patients actually shows late GI bleeds, but 1 is because of disease progression, 1 is lower GI bleeds, and then 2 actually had SMA pseudoaneurysm. That's pretty uncommon thing to see, but we do have 2 patients has that. And 1 patient is unknown because he didn't want anybody to scope him. So this actually phase 1 trial shows that concurrent SBRT, Norfinaver, 40 gray plus 1250 milligram BID is feasible and safe. Of course, you need to pay attention to your planning. So I actually was going to talk about also, we had another paper analyze all the patients who had the resection and what kind of dose need to be given to the duodenum. And we see some grade 1, grade 2 toxicity, but not grade 3. But somehow they didn't change my slides, so I will skip that part. I'll save some time. So this is the second trial. Actually, when we finished the phase 1, we were going to move into the phase 2. So you can see the phase 2 trial actually was the same kind of dose as a 40 gray in 5 fractions plus the 5 weeks of Norfinaver, 1250 milligram BID. And at the time, actually, we were trying to integrate it with this immunotherapy, targeted therapy drug. So CA-125 actually is a kind of tumor marker to indicate the tumor progression, metastasis. So when you use this oligovomat to combine the antigen antibody together, it will present it to the antigen presenting cells, and it will present to the T cells, and will have actually reverse the immunosuppressive effect of CA-125. So that was the reason we actually integrate this into our trial. So what we did was that, the objective, of course, was going to see whether this chemoimmunotherapy was going to be more effective, and also we checked the safety. What we did was that we picked those patients who had CA-125, 10 units per ml or higher, and those patients will get the oligovomat. We have 3 cycles of chemotherapy pre-op, And those 3 cycles, each cycle will get 1 dose of oligovomat. So those 3 doses. And then we also have the same 3 cycle chemo after the surgery. So they will get 3 doses after surgery. And then we also get 1 dose before, between SBRT and the surgery. So 4 doses will be 7 doses, okay? Not everybody actually received that, but that was the plan. And then the rest of the treatment exactly the same as 44107. And the patient characteristic exactly almost identical to the phase 1 study. And this study, actually, we only accrued 11 patients. We were still accruing, however, because of the new, more effective chemo regimen is coming out, like Dr. Crudy was telling you, for FOLFIRINOX and gemcitabine Abraxane was more effective than this old one, gemcitabine and 5FU. So we forced it to close. So this one actually was only 11 patients, but we still analyze it because we still actually found something more interesting about this immunotherapy. And the side effects, actually, this is one, you can see the more side effect than the one without oligovomat. And we basically need to pay attention that we do have some more side effects from if you use that combined treatment. The overall survival, quite similar to 44107. We don't see too much difference. Again, this is only 11 patients. And again, with this immunotherapy, we basically did the lab test. Only 5 patients actually checked the CD8 T cells immunity. We found the 2 patients actually with a strong positivity. Those 2 patients had survived the 30 to 31 months, but the rest of they didn't get the 7 doses. And we went back to see those 2 patients actually got the 7 doses. So this trial, although it's not complete like what we wanted, but it actually shows that immunotherapy probably is still a way to go. So we need to reevaluate this kind of regimen with a better systemic regimen, and that was still in the future possible direction. Okay, so then we actually went into this current trial. This one is a 55216, still ongoing. And this one is totally based on our lab results, based on Dr. Butler's lab, and Mike's also in there. We were all doing this. We found that the cholesterol pathway actually is associated with pancreatic cancer resistant to radiation. So at the time, we actually Dr. Butler's talk was a very good introduction of this trial. So you basically understand everything, why we designed this trial, and I don't need to go through that one anymore. So basically this trial is a phase 2 randomized trial. We have the patient in one group with standard chemo followed by SBRT and with concurrent 5FU or capecitabine, and followed by surgery. And the other arm, exactly the same, but at Zomera with the SBRT. So this trial actually going well, and the primary objective is to see the efficacy of the combining with Zomera. This trial also, the chemo regimen is different from the old one. So all the patients were now to get either FOLFIRINOX, 6 to 8 cycles, and sometimes even they do more if the patient is still have unresectable disease. And then also, if they cannot tolerate FOLFIRINOX, they can use Gemza and Abraxane. So So this is our ongoing trial, and I'm going to show you just two interim analysis. The first interim analysis was trying to see whether Zometa is safe, although Zometa is not a new drug, but we never used it this way. So we still need to prove it's safe. So after 6 subjects, we found that there was no patient actually had the grade 4 or higher hematologic or non-hematologic toxicity. So after the 6 subjects, we keep going. The second interim analysis is after each group has 11 patients. And the trial defined that if we have, among 11 patients, if we have 5 patients or less local control in each group, then we have to stop the trial. And we didn't see any patient actually had the local failure. And we do have, each group have 4 failure, but they are all distant, either liver or distant lymph nodes and mesentery nodes or ascites. And then the other one also, you can see the liver, peritoneal, lung. So again, our trial always showing that the patient are more likely to fail at distance. So because of this reason, so we continue this trial. And we also analyzed the overall survival. We, against our phase 1, if you still remember, I show you, it's a 44107. The green one is 4417, and then the 55216 is a new trial. Both actually is better than the 44107, and more importantly, it's very promising. Seems like the arm with Zometa is doing better than the arm without Zometa. So we are continuing our trial. So I was going to have more fun here, has a picture, but it's not here anymore. That's fine. That's all for me.